Hi, my name is Rebecca Robinson, and this is my presentation on chronic venous stasis ulcers. Veins are responsible for carrying deoxygenated blood back to the heart from various bodily tissues. The venous system operates at a relatively low blood pressure, relying on the concentration and expansion of the skeletal muscles to propel blood past the one-way valves in the veins on its way back to the heart. The circulatory system relies on the pressure gradients to push blood through the arteries and into the veins. When this pressure gradient is inhibited by blood clots or valve deficiencies, the blood can pool and create larger clots, causing venous stasis ulcers. The right image demonstrates normal venous forward flow with a healthy valve that prevents blood backflow. Next to this, you see dilated or clotted valves that allow blood backflow, which can lead to venous ulceration. Varicose veins can lead to venous ulcers. These are the result of malfunctioning venous valves causing pressure in the veins to increase. These typically occur along the medial or lateral distal lower leg. The resulting venous hypertension causes blood pooling when it is not as efficiently pumped back towards the heart, otherwise known as venous insufficiency. In addition, the increase in pressure stretches the vein walls, allowing proteins in the blood and blood cells to leach into the subcutaneous tissues, resulting in edema and the eventual breakdown of said tissues due to the lack of oxygen and nutrients. Specifically, deposits around the capillaries of the protein fibrin, which normally plays a role in clotting, prevent oxygen and nutrients from flowing to the surrounding muscle and tissue, and in turn lead to necrosis and ulceration. This is known as the fibrin cuff theory. Venous ulcers present themselves as shallow, painful ulcers located over bony prominences, particularly the gaiter area or the ankle bone. Granulation tissue and fibrin are also present. One most likely will also be diagnosed with these associated findings in addition to chronic venous stasis. These include edema, venous dermatitis, varicosities, and lipodermatosclerosis. Venous ulcers are the most common etiology of lower extremity ulcerations. They account for 85% of lower extremity diseases. Live counts of the U.S. population report that there are 328,971,520 people currently living in the United States today. 1% of that population is a little over 3.2 million people. 1% of the U.S. population are affected by this disease. Any condition that causes blood to pool in the veins of the leg is a potential cause of the venous ulcers, including varicose veins, deep vein thrombosis, or heart failure, of which are differential diagnoses of venous ulcers. Most venous ulcers are caused by venous valves that do not properly prevent the backflow of blood, also known as venous reflux, from deep veins back to the superficial veins located between the skin and muscles. In addition, any condition resulting in muscle weakness in the lower leg can decrease the skeletal muscle's effectiveness in propelling blood back toward the heart. Here is a comprehensive list of other medical conditions that can cause venous ulcers. The physiology of venous ulcers is not entirely clear. Venous incompetence and associated venous hypertension are thought to be the primary mechanisms for ulcer formation. Factors that may lead to venous incompetence include immobility, ineffective pumping of the calf muscle, and venous valve dysfunction from trauma, congenital absence, venous thrombosis, or phlebitis. Subsequently, chronic venous stasis causes pooling of blood in the venous circulatory system, triggering further capillary damage and activation of the inflammatory process. Leukocyte activation, endothelial damage, platelet aggregation, and intracellular edema contribute to the venous ulcer development and impaired wound healing. Let's talk about the common risk factors that can lead to venous ulcers. Higher risk factors include old age, previous leg injuries, deep venous thrombosis or blood clots in the legs, and phlebitis, which is an inflammation of a vein. again usually in the lower extremities. Venous ulcers are also more common in women than men. Diagnostic studies used to investigate venous ulcers include the ankle brachial index, Doppler ultrasonograph, Doppler bidirectional flow studies, and venography. It is rare that vascular imaging is used to confirm or deny venous ulcers because of the superficial manifestation of the disease. It is easy to investigate on the surface of the skin, augmenting the need for further exams. The main two purposes which vascular imaging would look for in diagnostic ulcers are perforating veins with signs of reflux. This is more of a verifying test to see possibly where the blockage is. This does not usually affect the treatment of venous ulcers. Due to the fact that there are venous ulcers present, it is inherently known that there must be some venous vascular insufficiency caused by the blockage or perforation. This image is an example of a perforated vein. We know this is a perforated vein because of the blue flow going away from the transducer. This is stemming into the tissue from a superficial vein. Venous reflux is identified with backward venous flow. Reflex flow is rated in severity as a time measurement of the reversal period. In other words, reflex is determined by compressing and rapidly releasing the distal leg and measuring the duration of reversal flow at the beginning of reflex and at the end. In the beginning of stasis ulcers, you will notice skin redness and inflammation of the subcutaneous tissue in the area of the lower leg. Next, the inflamed skin starts to leak fluid. Then, small white or yellow areas of dead skin appear. Eventually, the progressed wound surface becomes a venous ulcer. Without treatment, one of the most typical complications associated with venous insufficiency ulcers is infection of the affected tissue. Procrastinating treatment is a dangerous decision, and in severe cases could lead to gross infection, needing some amputation. Now that we understand this disease, let's meet our patient. This is Carl. Doesn't he look nice? Well, maybe a tad grumpy. This is understandable because, unfortunately, Carl has had some bad luck and has been diagnosed with chronic venous insufficiency ulcers on his left calf near his ankle bone. Carl is a heavy smoker, smoking 1 pack of cigarettes a day, and has a history of varicose veins as well as tight, itchy, and painful feelings in his left calf. He has a history of untreated hypertension, arterial compromise, and refused revascularization. Normal ankle brachial index is 1 to 1.4. Carl's lab results showed that he had an ABI of 0.8. An ABI between 1.4 and 1, which is similar with Carl, is a moderate amount of blockage, inhibiting the blood from reaching the legs and feet. Treatment options for venous ulcers include conservative management, mechanical treatment, medications such as aspirin or antibiotics, and surgical options. In general, the goals of treatment are to reduce edema, improve ulcer healing, and prevent recurrence. Although numerous treatment methods are available, they have variable effectiveness and limited data to support their use. Treatment methods include compression therapy, leg elevation, and dressings to pull out infection. It is important that dressings be changed 3 to 4 times a day for the first few weeks. Overall, acute ulcers, duration of 3 months or less, have a 71 to 80% chance of healing, whereas chronic ulcers have only a 22% chance of healing after 6 months of treatment. Given the poor healing rates associated with chronic ulcers, surgical evaluation, such as removal of the necrotic tissue, should be considered. Figure A is 4 months post-treatment of wound care dressings. When Carl appeared at the clinic, his venous stasis ulcer appeared weepy and extremely inflamed. Healing was also stalled by a recurrence of fungal yeast infection on the periwound skin. The initial size of the ulcer was 4 by 4 by 0.5 centimeters. Carl stated that the itchiness was gone within 1 week of the application. Figure B is 2 weeks following the initial use of the Elextra brand of wound dressings. Drainage is considerably decreased and periwound erythema is completely resolved. Signs of inflammation are no longer present, and the wound is nearly level with the periwound skin. Figure C shows 1 month of using dressing treatment. The wound size was reduced to 0.5 by 0.25 by 0.25 centimeters. The wound appeared optimally moist and mostly re-epithelialized. Figure D, the venous stasis ulcers completely closed with excellent aesthetic results after only 2 months of dressing care. Carl was extremely pleased and went home within a few days of completing his treatment.